Welcome to the Friday academic meeting, which is hosted by the Division of Endocrinology today. We've got Dr. Mansfield, who is a fellow in our department, will be giving us a talk on titled Crumbling Bones, but it's a focus on hypophosphatemia and osteomalacia. And Brett is a fellow in our department, but has recently qualified as an official endocrinologist. So congratulations, Brett. We've also got our reps here today. They brought on some snacks, but they're from Novo Nordisk. And I'm sure they've got something valuable to share with us just before we start the meeting. Good.
Good morning. We're from Novo Nordisk. I'm Zoliswa, the representative, and this is our medical advisor, Bunolo. I just want to share with you that we're from Novo and we have a drug called Saxenda, which is for your patients that are struggling with obesity. And it comes in a pen format and it's a daily dose for your patients. On your tables or on your desk, I've actually left a card like this. It just tells you a little bit more about Saxenda because it is a GLP-1 and it is registered in the country for obesity for your patients. When you are prescribing it for your patients, it starts from a dose of 0.6 and then we up titrate to 3 milligrams. The injection under normal circumstances, you will up titrate every single week, but also you can use your patient's tolerability when you are up titrating. For example, if you've got a younger patient from the age of 12 to 18, because we are registered from the age of 12, if your patient tolerates a particular dose, say they tolerate 1.8, that can be the highest dose that they stay on and maintain on. For your adult patients, they can up titrate maybe every second week or so until they get to the most desirable dose where they are going to lose their weight. The biggest side effects that we are seeing from patients are your GI side effects, which is your your nausea or your vomiting. So you can prescribe something for your patients to assist them, but also maybe go slower when it comes to up titrating the dose as well for your patients. And also advice for patients is to maybe stay away from fatty foods and just watch their diet. For advice and education and training for patients, we do have Sister Ntabiseng, who is a Novo employee. I did share the letter with Dr. J, and I will share the numbers with him as well so that you can contact her. And when you do have those patients that you want to be coached by Sister Ntabiseng, she can do that and at any time when the patient is available. I don't know.
And then when it comes to the side effects, the nausea, it is transient and all the side effects are transient. So the patients don't lose weight because of the side effects. And what we've also noticed is that the nausea is there as well as a trigger. So as much as it's transient throughout the day, you shouldn't be feeling nauseous consistently. But when your patients start overeating, it kicks back in to stop them from overeating. Even with the rich foods, when they start overeating that as well, it kicks back in again and they start feeling nauseous should they want to binge eat. So the nausea is transient, but it's also there as to basically stop the patient from overeating. We also advise the patients to drink a lot of water, especially for those that do experience headaches. And when they do eat, because it is an appetite suppressant as well, it is advisable for your patients to eat more proteins so they don't lose muscle mass. They retain muscle mass and rather lose more fats. And yeah, it's a once-a-day dosing. So unlike your homogeneous GLP-1 with a half-life of 2 minutes, this one has been engineered to last 13 hours. So you do use it once a day injection. And yeah, that's it.
Thank you.
Thank you.
Thank you.
Okay, morning everyone. Thanks for coming to this meeting. I'm going to be talking a little bit about a case that was in the news a couple of years ago, but also a case that we saw at Charlotte last year. Okay, so this was published in the Washington Times 2 years ago, or 3 years now. And this was about a software engineer from the Philadelphia area. His name was Ram Gajafeli. And he presented to his local doctor with left ankle pain. And he was advised to rest and elevate the leg and do all the good things that GPs would tell him. But he had a progression of pain, which began to involve his shoulders, his back, and his feet. He went to multiple specialists, including an internal medicine physician, rheumatologist, podiatrist, 2 orthopedic surgeons, 2 are better than 1, and as well as a physiotherapist who eventually suggested that the problem might be in his head. He went for MRIs, which identified what looked like a stress fracture of his ankle, and he couldn't understand why he would get a stress fracture. He was a generally well, healthy software engineer, and his doctor said to him, well, at least it's not getting any worse. He soon found it painful to lie flat, and he couldn't get up from a seated position. Of course, if you're in the US, you would, and you don't know what's going on, you test for Lyme disease, but it was negative. A rheumatologist found, found nothing untoward, and a neurologist also found no neuromuscular problems on an EMG. He was also suggested to change his brand of shoes. So he was a bit desperate, and on a trip to India, where he was visiting family, he was suggested by a friend to visit one of the physicians there. And it was the physician who, after ordering some blood tests, found that his phosphate level was low. And fair, in the US, phosphate is not part of a standard panel of blood tests. You don't order a CMP, you have to order it separately. So it was never picked up. In a case closer to home, we saw a patient, a 47-year-old male patient in our metabolic bone disease clinic. He had been referred from the spine clinic after developing multiple non-traumatic vertebral compression fractures. And he was referred to us with this DEXA scan. You may not be able to see from there, but he had Z scores because he was under the age of 50. But his Z scores were in the order of -3 to -6. And just a reminder that a Z score compares the bone mineral density to individuals of the same age and gender, whereas T scores would compare your values to a young person with healthy bones. And his Z scores on his hip were also very, very low. So he reported bone pain for the last 18 months. He had subsequently developed difficulty in walking 8 months prior, which he then required the assistance of a walker. And at the time when I saw him, he was wheelchair bound. He was a permanent resident at Selby Hospital, where he had been institutionalized since 1994 for schizophrenia. He was known to be on antiretroviral therapy for the last 6 years and had previously been treated for TB. Of note, he had suffered a right radius fracture 4 years previously, but he wasn't able to provide much detail around the circumstances related to that fracture. His therapy included a number of psychotropics, as well as sodium valproate, antiretrovirals, vitamin D, and calcium supplementation. There was no family history. He was a smoker. His examination was notable for a slender gentleman who was wheelchair bound and required significant assistance in mobilizing to the bed. He did have some clubbing and nicotine staining of his hands, but had no lymphadenopathy, and the rest of examination was otherwise unremarkable. Clinically, there were no skeletal deformities. He was noted to have significant proximal muscle weakness in his legs, but no other neurological abnormalities. His blood results revealed a normal UNE. His CMP showed a phosphate which was low and a significantly elevated alkaline phosphatase in the setting of a normal gamma GT. Okay, so phosphorus is critical for life. It is one of the most abundant elements in mammalian tissues. It has important roles in growth and development. It serves as a buffer in acid-base regulation. It forms a molecular backbone for DNA, and it's an important energy store in the form of ATP, adenosine triphosphate. It's involved in a number of enzymatic reactions such as glycolysis and influences protein functions, signaling cascades in the intracellular environment, and relevant to this talk, bone mineralization. So calcium and phosphorus are the principal minerals which comprise bone. Together they make up about 65% of the weight of bone. 99% of the body's calcium is found in bone, where in comparison about 85% of the body's phosphorus is located in bone. So the rest may be divided into either organic or inorganic phosphate, where organic phosphate forms a part of the intracellular elements, and inorganic phosphate circulates either protein bound in the serum or complexed with other cations. About half of circulating phosphate circulates free. So phosphate is regulated within quite a narrow range, around 0.8 to 1.4. And this is influenced by absorption from the diet, release of phosphate stores from the bones, as well as reabsorption from the renal tubules. And these mechanisms are regulated by a number of endocrine means, and these are specifically three hormones: FGF23, parathyroid hormone, and calcitriol, or the activated form of vitamin D. Oh, sorry. So FGF23 is one of the hormones. It's a hormone that is secreted by osteoblasts and osteocytes in the bone. So dietary phosphate will increase FGF23, and FGF23 decreases the absorption, so it's phosphaturic, causes an increase in renal excretion of phosphate, but it also decreases calcium. Thyroid hormone secreted by parathyroid glands is expressed in bone cells as well as the proximal tubular cells in the kidney. Although its principal role is maintaining calcium homeostasis, it has a net effect on phosphate, and that it is phosphaturic. But an increase in phosphate also has some negative feedback role and stimulates PTH release at the parathyroids. PTH has an effect on FGF23 secretion, promoting its effects. And then the final hormone is calcitriol, which is activated vitamin D, and this binds to vitamin D3 receptors to promote intestinal absorption of both phosphate and calcium. Calcitriol increases FGF23, whereas FGF23 decreases calcitriol, and PTH has an opposite effect on the activated vitamin D. So in the kidney, phosphate is handled by three classes of co-transporters: sodium phosphate receptors or channels, and reabsorption from the urine occurs via these NAPI channels in the proximal tubule. So FGF23 and parathyroid hormone would reduce absorption by reducing the expression of these receptors in the proximal tubule. So this is a little bit busy, but in summary, it really shows that a rise in serum phosphate leads to a secretion of FGF23 and parathyroid hormone, which promotes the loss of phosphate in the urine. And this is just a summary of some of the hormones which are regulated by phosphate. So as phosphate increases, FGF23 and PTH are also increased, which serve to regulate phosphate in a downward concentration. So then the mechanisms of hypophosphatemia are either by increased renal excretion, a decrease in the intestinal absorption of phosphate, but also in alterations in the shift from the extracellular to the intracellular environment. So the an increase in renal excretion may be either FGF23 mediated or non-FGF23 mediated. The FGF23 mediated conditions are maybe inherited. So these are some of the causes for hypophosphatemic rickets, but may also include a TIO, which is tumor-induced osteomalacia. Non-FGF23 mediated conditions, the most common, most likely, is hyperparathyroidism, the excess of PTH inducing phosphaturia, but diuretics, especially acetazolamide, which acts on the proximal renal tubule, may lead to hypophosphatemia. And then inherited causes such as Fanconi syndrome, which may also be as a consequence of drug-induced toxicity, of which there are a number of drugs. Impaired intestinal absorption or intake of phosphates is quite rare. The phosphate is found in almost all foods, and it's unusual to encounter someone who has hypophosphatemia as a result of purely reduced intake. But malabsorption is important, along with phosphate binders, and in particular antacids may lead to impaired intestinal absorption of phosphate, and then vitamin D deficiency. Since calcitriol, the activated form, is responsible for absorption of phosphate at the intestine, deficiency of vitamin D may lead to hypophosphatemia. Any disorder which leads to malabsorption of calcium, phosphate and vitamin D may lead to hypophosphatemia. Transcellular shifts may occur in refeeding syndrome, patients treated for DKA, receiving insulin infusions, and in some other disorders. So hypophosphatemia can be seen as having skeletal manifestations, these being rickets in children and osteomalacia in adults. But there are some extraskeletal manifestations which may be present in those with severe hypophosphatemia. And this is usually phosphates below 0.4, 0.3. Since phosphate is an important component of energy metabolism, adenosine triphosphate, a patient might experience encephalopathy. Cardiac manifestations include ventricular arrhythmias, as well as impaired contractility, and lead to worsening of heart failure. There are some pulmonary manifestations, typically diaphragmatic contractility may be impaired. And this would usually be seen in the ICU, where patients struggle to get off ventilators. It also affects both skeletal and smooth muscle, and can lead to proximal myopathy, paralytic ileus, and very rarely rhabdomyolysis. There are some hematological manifestations that are described in severe hypophosphatemia, and this may be mild thrombocytopenia, rarely hemolysis, as well as impaired chemotaxis of white blood cells. So in the bone manifestation, typically osteomalacia, and this is the inadequate or delayed mineralization of osteoid in mature bone. So in the remodeling cycle, the resting trabecular surface is essentially excavated by multinucleated osteoclasts at B, and then they go through a phagocytosis by osteoclasts. It develops a pit within the trabecular bone before recruitment of osteoblast precursors to the resorption cavity occurs. And this is where there is secretion of new matrix or osteoid at site E, and the secretion is by osteoblasts. After this, after the secretion of matrix, there is calcification of the osteoid, which is the black areas, completion of mineralization occurs at G. The bone then returns to a quiescent state with a very small deficit in bone mass. And this modeling or remodeling of bone occurs continuously. So osteomalacia then is the inadequate or delayed mineralization of that osteoid, which is laid down by the osteoblasts. The prevalence of osteomalacia is not entirely known, and vitamin D deficiency is probably the best marker of possible osteomalacia prevalence. But this varies widely throughout populations and depending on recommended reference intervals. The symptoms of osteomalacia include bone pain, muscle weakness, and may be evident as skeletal deformities and of course fracture. The most common causes being vitamin D deficiency, calcium deficiency, and phosphorus deficiency. And in patients with nutritional osteomalacia, which is principally due to vitamin D, you might encounter calcium and phosphate abnormalities in around a third of patients. The urine calcium would be predictably low as PTH is recruited to reclaim calcium from the renal tubules. Of course, vitamin D would be low. Alkaline phosphatase is almost always elevated, as is PTH. So there's also some imaging modalities which may point you towards osteomalacia. And if we quickly look at an X-ray such as this, we might discard it and suggest that it is normal. But we have to look carefully for the typical features, which are called looser zones. And that is a looser zone, which is a transverse lucency with surrounding sclerotic borders. And this traverses through the bone, usually starting at the medial end of the femur. And it's usually perpendicular to the cortex. Looser zones contain regions of demineralized osteoid. Importantly, since many patients with osteomalacia have secondary hyperparathyroidism, there may also concomitantly be features of osteitis fibrosa cystica, which I won't go over here. Again, here's another X-ray, and if you are not an astute clinician or physician, you might miss a small looser zone on the medial aspect of the femur. Other described bone abnormalities include codfish vertebrae, and these are biconcave vertebrae, which are not specific to osteomalacia, can also be seen in osteoporosis and other metabolic bone disease. So back to our patient, you can see that, well, we suspected that he may have osteomalacia given his symptoms, as well as his biochemical abnormalities, but his vitamin D was normal, and this would have been the most common cause for the osteomalacia. PTH was low, or in the low normal range, so this was not the cause for his hypophosphatemia. We suspected that this may be due to renal phosphate wasting, so urine was sent off to look for phosphate in the urine. His inorganic phosphate measured 12.3 and his creatinine was 13. He had no amino aciduria and no glycosuria. But to assess renal phosphate wasting, we have to calculate the proportion of phosphate that is reabsorbed according to the patient's GFR. So this corresponds to a theoretical lower limit of serum phosphate below which all filtered phosphate would be reabsorbed. This is referred to as the tubular maximum reabsorption of phosphate, or TMP. So this is a calculation which I don't think you necessarily need to know. We need to know it's in endocrinology, but we basically calculate the tubular reabsorption of phosphate. Based on this equation, which looks to be quite complicated, we plot the patient's plasma phosphate across a normogram, measuring the tubular reabsorption of phosphate, and calculate the renal threshold for phosphate concentration. And low values are indicative of renal phosphate wasting. The normal for an adult is roughly between 0.8 and 1.4. So our patients measured 0.4, which is indicative of renal phosphate wasting. So I mentioned briefly about some of the different causes of hypophosphatemia, and since this is renal phosphate wasting, it can be divided into FGF23 dependent or FGF23 independent causes. The dependent causes are maybe inherited disorders of rickets or tumor-induced osteomalacia. FGF23 independent causes may be Fanconi syndrome or a drug-induced tubulopathy or hyperparathyroidism. Our patient had a normal parathyroid hormone, so that effectively ruled out that cause. So we did not suspect an inherited cause, and one condition that we considered was tumor-induced osteomalacia. So tumor-induced osteomalacia, also known as oncogenic osteomalacia, is a paraneoplastic syndrome of renal phosphate wasting. So although it's paraneoplastic, it's usually a benign tumor which leads to this condition. It's very rare. Its incidence is not known, but there are around 1,000 case reports in the literature. And it is due to a mesenchymal tumor located in soft tissue or bone, which secretes FGF23, promoting phosphaturia. So as I mentioned earlier, if excess FGF23 leads to this renal phosphate wasting and impaired activation of vitamin D, and this leads to severe chronic hypophosphatemia. There is usually an absent family history when interrogating these patients, and they may present with osteomalacia, fracture, muscle pain, and severe myopathy. The tumors are located in bone, the other half being in soft tissue or the skin. Most arrive in the extremities, and there's we've had a couple at some of the BITS hospitals. Prof. Raul always speaks of who had one behind her knee. They occur in strange places and are quite small. So in locating them, we would favor imaging modalities through nuclear medicine, but tumor location is often delayed and takes up to 2.5 to 5 years. And the news reports, which I described earlier in the Washington Post, where a patient went from doctor to doctor, was a case of tumor-induced osteomalacia, which took years to diagnose. And many tumors are never localized. Okay, the other condition which we considered was Tenofovir-related hypophosphatemic osteomalacia. And as we know quite well, Tenofovir is an NRTI, which is used in the treatment of retroviral, typically HIV and hepatitis B virus infections. It comes in two preparations, TDF and TAF. It is known to have both renal and bone toxicity. And the patterns of kidney injury include proximal tubular dysfunction, so a Fanconi syndrome, acute kidney injury, chronic kidney disease, as well as rarely nephrogenic diabetes insipidus. The proximal tubulopathy due to tenofovir is actually not uncommon, and depending on the study that you look at, it may be as high as 25 to 30%. So one strategy to reduce TDF-induced bone loss has been thought to replace the TDF with TAF, tenofovir alafenamide, which is a prodrug and tends to concentrate more in leukocytes and is felt to have less renal and bone toxicity. So a few years ago, in a summation of two trials, which evaluated TAF compared to TDF, The drug was non-inferior with regards to its effects on the HIV virus, but was thought to be less renal and bone toxic, with bone mineral density after about 1 year not as affected by the group taking TDF. So the group taking TAF is the blue line, and TDF is the red line. So both groups had reductions in bone mineral density after a year, but to a lesser degree, the TAF. Importantly, no phosphate was measured in blood or urine, which I think would have been of value. A study which did evaluate hypophosphatemia in patients with on tenofovir looked at whether there was any benefit in switching those with persistent, confirmed or sporadic hypophosphatemia to those with switching TDF to TAF in those with hypophosphatemia, and they essentially found no difference. They had 2 patients who did not have hypophosphatemia, who developed persistent hypophosphatemia on switching drug, and there were 4 patients who had resolution of their hypophosphatemia. In a study evaluating 158 patients taking tenofovir compared to those who were not exposed, and this is these are patients taking TDF for HIV pre-exposure prophylaxis. They found that over a period of 10 months, there was a mild mean numerical decline in serum phosphate, but it was not statistically significantly different from the comparator arm. But you can see from this plot that there is, it's quite heterogeneous, and while we may not be concerned with those above the line, the patients below the line would be of concern. So what happened to our patient? Well, we changed the tenofovir, but we didn't change to TAF. We changed to abacavir. We gave the patient calcitriol and increased the dietary phosphate via a dietitian. We took blood to measure an FGF23 level, which we can't measure in state, and that would have been of value because that would have helped to distinguish between a potential tumor-induced osteomalacia or purely a renal tubulopathy. That is stored for research purposes, and given the severity of condition, we did elect to do a gallium dotatate scan to try and identify a small mesenchymal tumor, but it was negative. The patient followed up 6 months later after changing, well, intermittently over the next 6 months, but by 6 months, he was now no longer wheelchair bound, he was walking unaided, and his phosphates had returned to normal. A repeat of his urine phosphate showed that he was no longer phosphate wasting. And just to highlight that there have actually, over the last 1 to 2 years, there have been at least 5 patients which are similar to this case that are presented. And I think there are, and that was just at this hospital, I think there are probably many that we are missing. So just some take-home points. Hypophosphatemia is not uncommon in clinical practice. It's important to remember that not all causes of a reduced bone mineral density are due to osteoporosis. So consider osteomalacia, and especially those who have symptoms related to bone pain. They may have gait disturbances and proximal myopathy. And importantly, distinguishing patients with osteoporosis and osteomalacia, it's not only the symptoms, but usually patients have, or they may have biochemical abnormalities in calcium phosphate or vitamin D. It's important to find and treat the underlying cause for osteomalacia. Sometimes it can be quite complex, whether it's a genetic cause or a rare cause, such as tumor-induced osteomalacia, but it may also be a common cause, such as tenofovir. Interestingly, switching from TDF to TAF may not alter hypophosphatemia, but I think this is perhaps something that's we could potentially do at our hospital and look at our patients, because there isn't much in the way of studies to look at switching these drugs. And that's it. So I'm happy to take any questions if there are any.